Hello, my name is Cassandra Wright, and this is my DNP project entitled Evidence for Creating More Inclusive Clinical Practice Guidelines to Improve Care of the Lesbian, Gay, Bisexual, and Transgender Patients. Here are the committee members for this project, including Dr. Kern, who acted as my chair, second reader, Dr. Brunworth, and my committee member, Maria McQueen. The facility in which my project was completed is a 44-bed acute care hospital in coastal South Carolina. The focus was providing evidence to facility stakeholders that the current educational model for healthcare workers on culturally competent care of the lesbian, gay, bisexual, and transgender patient, known moving forward as LGBT+, is insufficient based on evidence-based data. The PICO question posed to start this project was for the administration of a hospital as the evaluation of a clinical practice guideline, CPG, on the cultural needs of the LGBT+ community using the agreed-to instrument as compared to the current facility guidelines on cultural competency education, provide consensus among stakeholders to support the implementation of the CPG at the chosen facility. The current educational module that is provided to facility staff on cultural competency is one annual PowerPoint presentation with 20 to 25 slides covering 20 different cultures. For the LGBT+ patient, there is exactly one slide, the majority of which is dedicated to covering definitions of terms for patients within the LGBT+ community and does not address healthcare disparities or unique needs of the LGBT+ patient. Culturally competent care is care that is provided with the knowledge and understanding of how the patient's social, economic, and racial background may impact how they perceive and seek healthcare. Using that knowledge to help further the healthcare worker-patient relationship and to tailor care for the patient is providing culturally competent care. This means understanding that some patients will experience disparities and healthcare access issues related to their culture. As nurses and advanced care providers, the roles require advocating for each patient to receive the best care possible based on their individual needs. When caring for LGBT+ patients, this means knowing that this population experiences an increase in poor health outcomes and disparities, including being less likely to be fully insured. Current evidence-based literature was reviewed using a series of search terms yielding over 5,000 articles for the term cultural competency and less than 100 articles each for the terms related to LGBT+ health and LGBT+ disparities. 12 articles were identified as relevant and high quality for the use of this project. These articles were evaluated with a focus on 3 themes: impact of discrimination on LGBT+ population, addressing LGBT+ cultural needs using CPGs, and improving patient outcomes. These themes will be further discussed on the next few slides. Patients within the LGBT+ community are at a higher risk for certain chronic illnesses, including but not limited to obesity, mental health disorders, substance abuse, increased suicidality, late diagnosis of reproductive cancers, and cardiac disease. Fear of seeking healthcare by LGBT+ patients includes both fear from a history of actual discrimination from healthcare workers and fear of potentially experiencing discrimination from healthcare workers. Having had a bad experience with a healthcare worker or knowing someone who has makes a patient 3 times less likely to seek care. This has been made worse as there has been a shift in political culture that puts a higher level of fear in both transgender patients and in providers who provide healthcare related to a patient's transgender health care needs. LGBT plus patients tend to have a lower rate of being insured or are underinsured when compared to their cisgender heterosexual peers. Healthcare workers are not likely to receive much, if any, formal training on the care of the LGBT plus patient, with nursing programs providing less than 1 hour of formal training and medical schools providing less than 1 day of formal training on care specific to this community. These disparities can be addressed through clinical practice guidelines, including that of healthcare worker education. There are studies, including those from Kuzma et al., in which healthcare workers are asked to work with practice LGBT plus patients to address personal bias and practice asking history and physical questions that they might not typically ask regarding sexual history and gender identity. These practice patients have been shown to increase provider comfort and awareness when handling LGBT plus patients in actual practice. In studies where every patient presenting to a facility were asked their sexual orientation and gender identity, the trust rating for the facility from LGBT plus patients improved, while the non-LGBT patients did not complain or experience a difference in their care quality. Healthcare workers can benefit from training in which they are asked to look at their personal bias and how they may impact the way in which they are providing care. CPG development can be assessed using evaluation tools such as the Agree-to instrument to evaluate for high quality and reliability. LGBT plus patients are shown to have worse health outcomes when compared to their cisgender heterosexual peers. Part of these outcomes are related to later diagnosis and treatment of chronic illnesses due to missed screenings. This is especially true in reproductive screenings for transgender patients, either due to healthcare provider discomfort, patients not disclosing, or healthcare providers' lack of knowledge on the need to continue to screen for cancers such as prostate cancer in trans women and cervical and ovarian cancer in trans men. Patients are more likely to not seek care until they become very ill due to these fears. When providers are trained in cultural needs, they are more confident and comfortable in assessing for and treating those patient needs. Patients who feel as if their provider sees and cares for them are more likely to discuss symptoms that could be considered uncomfortable. Through the use of CPGs, providers can help to create standards to bridge the gaps in healthcare. This project was modeled after the theoretical framework of the Johns Hopkins Nursing Evidence-Based Practice Conceptual Model. This model follows 3 steps of identifying the practice question, as done in this project through the development of the PICO question, gathering the evidence, which was done through the literature review, and then translating the evidence into a clinical practice guideline. While for this project, the clinical practice guideline was not created or implemented, one was evaluated with evidence for change being presented. As this model focuses on the evaluation of an issue with a CPG being created or modified in order to address the issue, this theoretical framework is the most appropriate for this project. Following the Johns Hopkins Nursing Evidence-Based Practice Conceptual Module theoretical framework, this project was designed through first reviewing the current facility CPG, which, as discussed, is that one slide educational module for the LGBT plus cultural competency. And then through reviewing current evidence-based data on care of the LGBT plus patient, facility stakeholders were presented evidence-based data to show that there is a need to change the current facility guidelines. Stakeholders were then asked to evaluate the presentation and evidence presented using the Agree-to instrument. Facility stakeholders were selected through the inclusion and exclusion criteria that is listed on these slides. The major requirement included that of having a patient care focus to their role and being part of the committees that make policy changes. Those who did not have a patient care focused role and those who were directly supervised by the student were excluded. 10 stakeholders were selected. The chart on the left shows a breakdown based on the roles within the facility of the stakeholders, including nurse leaders, the medical director, and those who work in quality, informatics, and educational roles. The agreed to instrument recommends a minimum of 4 respondents for the data to be considered meaningful. So through having 10 stakeholders, there's a sufficient number of respondents for the data to be considered meaningful for this project. Stakeholders were asked to complete the agreed to instrument to obtain data for whether stakeholders agreed there was a need for change. This instrument uses 23 questions across 6 domains with an additional 2 global questions to gather and evaluate stakeholder feedback. Within the 23 questions, each is scored 1 through 7, with 1 being strongly disagree and 7 being strongly agree. Scale domain scores are created for each of the 6 domains and compared to a set domain threshold to determine if the CPG is high quality. The agreed to instrument recommends a minimum threshold of 70%. For this project, the threshold was set at 70%, with domains 1 and 3, which are scope and purpose, and rigor of development, being set at a higher threshold of 80%. To determine a scale domain score, one would use the formula of subtracting the total possible minimum domain score from the total obtained domain score, divided by the total possible minimum domain score subtracted from the total possible maximum domain score, which is then multiplied by 100 to get the percentage, which is being looked at for the threshold. On the right, you can see the breakdown of how many questions are in each domain, as well as the topics that are covered within that domain. 10 facility stakeholders were invited to participate using a third-party source to email out both the presentation and the link to the agreed to instrument in order to allow for a level of anonymity and reduce potential bias. 8 stakeholders responded to the agreed to instrument within the 2-week period that was set for project response. However, 1 respondent only filled out 10% of the tool, so that particular response was excluded due to not having enough information. On the right, you can see the responses to one of the global questions, which asks, would the stakeholder recommend the clinical practice guideline for use? In this case, 6 out of 7 responded with either yes or yes with modifications, with the final respondent replying no. The chart to the left on this slide shows the total possible maximum domain scores in blue and the total points that were awarded by stakeholders in red. The chart on the right provides the data needed to calculate scale domain scores, as well as the scale domain scores that were calculated for each of the 6 domains. The highest domain score obtained was domain 3, rigor of development, at 93%, and the lowest scale domain score received was domain 6, editorial independence, at 68%. The major limitation of this project is in the fact that there were not comments provided to gain further insight into the responses on the agreed to instrument. Additionally, due to the exclusion criteria of excluding those who were directly supervised by the student. No direct care nurses were included within the stakeholder pool. For all studies regarding the LGBT plus community, there are limitations in the amount of available evidence-based data. Some of this is due to very few studies have been done. A lot is due to the fears and requirements that self-disclosure is necessary to determine who is a patient that is considered under the LGBT plus umbrella. So those numbers are likely underreported. If repeated in the future, this project would have benefited further insight, both through including direct care nurses and requesting comments from the respondents on that agreed to instrument. For this project, the 70% threshold was met for domains 1 through 5, with the scaled score for domain 6 mean at 68%. Domains 1 and 3 did meet the tighter set threshold of 80%. Domain 6 focuses on whether the risk of or actual bias exists from either the presenter or the stakeholders regarding how the CPG is developed or the topic of the CPG. Due to the anonymity of the presentation, this type of disclosure was not fully met, which definitely impacted the score. Again, not having comments from the stakeholders reduces insight into why this was the lowest scored domain. Overall, the results establish that stakeholders agree there is a need to change the current clinical practice guideline. This project's implications for practice is through the establishment of the need for change to the current clinical practice guideline. It shows that healthcare workers need cultural competency to care for patients and need to continue to act as drivers of change. This project can serve as a baseline for future work in improving CPDs regarding culturally competent care of the LGBT plus patient. This project met its stated aim of proving to facility stakeholders the need for change of the current clinical practice guideline regarding staff education on cultural competency and the care of the LGBT plus patient through providing evidence-based data on healthcare disparities and healthcare needs of the LGBT plus patient. Looking towards the future, I plan to continue to assess for and work to bridge gaps in healthcare and healthcare access for the LGBT plus patient. Throughout completing this DNP program, I have learned more about my role as an agent of change within the healthcare system. This includes gaining more insight into how to properly read and evaluate scholarly articles, and gaining more awareness of the inequities in healthcare around me. Patients who are treated as a whole person and understood on their cultural level have improved patient outcomes. And LGBT plus patients who feel safe do not delay healthcare. Insights from this project, I believe, also include that healthcare workers who are aware of their biases and who have education on how to care for patients whose cultures are different from their own are better able to care for their patients and reduce healthcare disparities and improve overall patient outcomes. Here you can see the references that were used for this presentation. Thank you for your time and listening to this project presentation.